Oh, yes. That's the evaluation of benefits and harms of surgical treatment of post-radical prostatectomy, urinary incontinence, a systematic review and meta-analysis, and more or less did continue what the questions were for the former presentation.
Great, yeah, thank you very much. So I'm very happy to present to you this morning. This is the work mostly, whoops, I'm so sorry, of Roslyn Chouanière. She couldn't be here, she's our master's student, and this is her blood, sweat, and tears that I'm very happy to take credit for. So I have no disclosures. In brief, one of the unfortunate complications that occurs with prostatectomy is post-prostatectomy incontinence, which can occur up to 25% of the time. Typically, most of that gets better, but at 1 year, something between 1 and 10% of men will choose to go on and have further interventions for this. There's essentially 4 treatment choices depending on severity and degree of bother. So we can have injectable bulking agents, slings, artificial urinary sphincters, and adjustable inflatable balloons. But how are our patients meant to choose, right? So in order to make a good choice, our patients ought to have a very good sense of the trade-offs, in particular the benefits, harms, and burden of their choice, right, in the context of their values and preferences. So our contribution to this field was to conduct the systematic review using the highest rigor contemporary methodology to do so. In particular, this mammoth work involved sifting through nearly 3,000 studies to identify 85 of which had usable information, which represents about 13,000 patients from 19 countries. So I suggest this is fairly generalizable results. And as one might expect in a more contemporary group of studies, we'll have more information for male slings and AUS than the other interventions. Now, what's different from our work, the second difference is clearly we had a different inclusion criteria, so we could use more information, but as compared to a few other meta-analyses published in this space in the past 5 years, we have a much broader set of outcomes. So we have some 14 outcomes that we evaluated. So each one of those required systematic review meta-analysis. So a ton of work was done to really try and give our patients a fighting chance of balancing the benefits and harms of their treatment choices. And knowing at the outset that we were going to be dealing with limited quality of evidence, it's especially important to be very rigorous in evaluating the quality of our evidence. So we use the grade approach. I don't have time to get into, but in brief, in this middle column here, for each one of the outcomes I showed you a moment ago, we evaluated the risk of bias, inconsistency, indirectness, imprecision, and publication bias for each of those, right? So knowing we were starting with low certainty evidence, if there was one of these present in a significant way, we actually would rate down the quality to very low quality. And in some cases, very few cases, mind you, in our study, we were able to find a very large treatment effect in the absence of most of these, and we actually rated up the quality of evidence to sort of moderate. Now, we did not find any high quality evidence to support any of our outcomes here. In brief, so we did this, if you can imagine, 14 times for each of these interventions. So that's a whole lot of slides I can't show you, but in general, bulking agents had very low quality evidence for all outcomes. Slings had a little bit better evidence some of the time, but still mostly very low to low. PROACT was all very low and low quality, and artificial urinary sphincters, again, mostly it's very low, but once or twice we did rate up the quality of evidence. And we generated a whole bunch of tables just like this. So here I'm just using this for illustrative purposes, but a patient with a certain degree of continence may have a choice between sling and AUS. And in this case, you can see a clear trade-off. Now, only considering two potential outcomes is not the way to approach this. We'd want to consider all the relevant outcomes to that patient. But here I'm showing that we're reporting about a 59% continence rate at a little more than a year, so pretty short-term outcome here for slings, and that's inferior to the AUS, and this is actually not adjusting for probably more severe patient incontinence at baseline with AUS, but these seem to work better is where I'm going with this. However, the risks of undergoing an AUS are considerably higher than the risks of undergoing a sling as per the relatively weak evidence, right? Moderate here, which is quite good, but low in general. that we had to support that claim with. So for some patients who are more averse to complications and would tolerate a higher failure rate, maybe the choice for them would be a sling. In contrast to someone who has a higher interest in being dry, maybe they would choose an AUS. Now, longer term, we were able to give some longer term data for this particular set of outcomes, though not all outcomes because of the limited data we had, but a bit longer term, it seems the pattern is roughly the same. Okay, and we tried to look at many outcomes, and sometimes, in particular for patient-reported outcomes, what I'm highlighting here is there was a paucity of evidence. So we have really limited things to say to our patients, and some interventions, there really was nothing in the literature reporting on some of our, what we felt were patient-important outcomes. That's a problem. Whoops, I did turn that off, and that was a mistake. Okay, so in conclusion, the really take-home message I'm trying to sell here is that we have limited evidence for any of these interventions. And we are meant to be helping our patients within a shared decision-making framework, but we're working with a pretty big handicap here because we don't have a high degree of certainty in what we're actually telling our patients. And I think that's a problem, and even calls into question how all these devices make it to market with such limited evidence to support their use and, in particular, their harms. So I'm happy to take some questions now.
My name is Paul Faust. You can go first.
Okay, Jacques Orcos from Montreal. So Philippe, congratulations, it's a great study, well done, very well done study, and very depressing also, considering the fact that, honestly, I don't know what you are doing here. We should be all at home and studying what you are doing every day. The quality of evidence in incontinence, specifically in male incontinence, is awful. So what do you tell your patient today? What do you tell them exactly? Meaning that when you have, because he's a patient, if he is more willing to have complication or less willing to have, nobody wants to have complication, obviously. So what do you tell them exactly when you're facing a patient with stress and incontinence?
Yeah, no, so that's great. So actually, this is a bit the paradigm I'm trying to push. You know, this is not the only space in urology with limited evidence, right? And so what do you do when you're faced with a situation with a lot of uncertainty? Well, the first thing I'll start with is you don't just tell your patients what to do. You don't just say, well, this is what you should do now, get a sphincter and go home. We don't have, it's not clear enough that that is the only good choice for them. So I actually present uncertainty to my patients, right? I talk to them. I try and meet my patients where they're at, depending on their ability to understand what I'm saying. I spend a lot of time with them before we go ahead and do major interventions that are life-altering for them. And I just discuss. I say, this is what we think happens. This is what we think usually we would do. And here's the problem. These are a list of complications that could happen, and we're not so sure, actually. We have a lot of uncertainty of whether this is going to go wrong for you or not. How bad are your symptoms really? Because it all comes down to, can they live with it? And some men don't mind living with worse incontinence, and some men really hate it. And so it's a personal choice, and in the absence of very strong, clear winner of this has to be the way to go, you have to leave that choice in the hand of the patients, but not abandoning them, not giving them information they can't understand, saying, make up your mind, tell me what you want. I mean walking with them. I mean talking to them and spending that time, which is difficult in a busy clinic. You know, I see 40 patients a day, and sometimes I do spend an hour with a person, and that does screw the rest up of my clinic, but you know, that's my problem, not my patient's problem.
Yeah, thank you very much. This is an important work. However, as the outcome is not so clear, it doesn't really matter. But to me, there is a major weak point in this whole work because you cannot put together the fixed slings with the adjustable slings. I think that this should be put apart because they have different indications and different contraindications. And coming to the contraindications, I think that in practical life, it is a good way to approach the patient to tell him what is not good for him. You know, you should tell him you're not a guy for, if you're irradiated, you shouldn't have a PROACT, for instance, or if he's manually not able to use a sphincter, then you rule out the sphincter. And then maybe 1 or 2 methods are left, and then you can focus on them, and then you figure out what he would prefer and what your preference is and what your routine is. So this is a practical approach maybe, but of course we have no evidence for all that.
Well, I think that this is an issue, right? If you believe there's a big difference between 2 sling types in terms of indication or whatever it happens to be, then there should be evidence to back that up. And it should be easy for me to split that apart. You know, we did 14 times 4 different procedures worth of outcomes, and I would have been happy to do twice as many if there was adequate data to do so.
But I believe in the literature you can find that the fixed slings are not as good in the severe incontinence, and some of the adjustable slings are. So there's a really also
perhaps, but if it's not evidence enough that I was unable to find it, it's yet supporting the point that really this is a problem with how we're doing our research. We just need to be more organized.
We will never have head-to-head. We will never have the head-to-head studies on that one.
Well, we're waiting for the master trial to come out with the results. Rizwan,
and
last
also
question. Very small one.
No, also, thank you very much. A lot of hard work. What you didn't present in your quantification, there's anything of pad usage, how much pad was used, or can you quantify which one is better
yes.
according to the...
We certainly did all of those outcomes. I just, you know, there were so many to show, and we have 8 minutes or whatever, there's minimal time to show it. So we absolutely have all of those outcomes evaluated for each of the interventions that the data was available for. Off the top of my head, I wouldn't want to misrecite them, but if you feel like knowing, we can chat in front of the computer.
And then the last thing is that I think with our trial, the European registry, the prospective one, we're going to get answer of lots of these questions.
I hope so.
Thank you very much. Let's move on.
Thank you.